Hello and happy Wednesday, everyone. Thank you all so much for joining us this evening for our Hormones and Your Waistline webinar hosted by Dr. Alexandra Mayer. I'm Olivia with Ethos Integrative Medicine. I'll be moderating this webinar. Before we start, please remember to mute your microphones. And if you have any questions at any point in time, feel free to type them into the chat. We'll be sure to answer them at the end. If you have any specific questions pertaining to your personal care, we cannot address this tonight in this webinar, but I highly recommend scheduling a free 15-minute consultation with Dr. Alex. She'll be able to answer your questions and help you to navigate treatment options, and I'll go over more of that information at the end, so stay tuned. Today, we'll be diving into key hormones when we think about metabolism in women, how these hormones play a role together, what potentially has been missing if everything is normal, but you're still not feeling your best, and why hormone replacement is just so much more than just a prescription. So I'd like to start off the webinar by introducing our women's hormone specialist and medical aesthetics expert, Dr. Alexandra Mayer. She's passionate about helping her patients show up big in their lives, meaning that they feel great in their own skin and feel energetic, vibrant, strong, and beautiful. That's why her approach to care is designed to balance immediate improvement and long-term results. So I hope you all get the chance to connect with her. She's a fantastic resource for all things hormones, aesthetics, and skincare. And without further ado, I'll let her get started with her presentation.
Thank you so much, Olivia, for that introduction. Hi, everyone. Thanks for spending a little bit of your Wednesday evening with us. So this webinar is honestly one of the favorites that I give. Whenever I've given it, women get a whole bunch of information. I actually updated it today to put some new things in it for you guys. So hopefully everybody gets a little bit out of this. First of all, one of the things that I want to ask you guys is, how did you guys hear about our webinars? Miss Olivia over here does such a wonderful job of marketing our practice basically. And we want to just know what's working. So if you want to pop into the chat and let us know how you heard about the webinar, that would be amazing. So Olivia gave you a little bit of an introduction for me. I'm going ahead. All right. And this is a little bit of the introduction to the talk. So honestly, we're going to be going over the main hormones that we think about when we think about metabolism in women. Now, metabolism is tricky, right? There are a lot of things to consider. And we do have other resources that I will point you towards that can be really helpful as well at the end of the talk. But we're going to be talking about the main hormones that we consider. We're going to be talking not so much about hormone replacement. We are going to talk about it a little bit, but we're going to talk about why it is a balance between all of the hormones. And then we're going to talk about some things that you can actually do at home and change in your life, which is going to be great because really at the end of this, you guys want to get an idea of what you can do to make your life better, right? So let's kind of start by talking about why sometimes female metabolism isn't really treated super duper well. And I think that some of that is because we like to put blinders on in medicine, right? We like to go, I treat your thyroid and I treat your female hormones, and we don't talk together. And really what we know is that female hormones, you have to be able to have the communication between all of the hormones, and they really do all play together. And so all of that matters. So let's dive in. When we think about weight, what's the first hormone that we think about, right? Everybody thinks about their thyroid. And so for those of you that don't know, your thyroid is this butterfly-shaped gland kind of at the base of your neck, and it makes two hormones, T4 and T3. If I had one thing that I think wanders in my office where I look at labs and I go, did anybody tell you about this? Shocked that nobody's ever mentioned it. It is pretty much always thyroid. So thyroid, in terms of the way that we treat it and the way we assess for it, is really important. And it can be really kind of nuanced. So when we look at this diagram, right, the things that we're thinking of, first of all, we're thinking about the brain. So the brain creates TSH, which is thyroid stimulating hormone. And thyroid stimulating hormone then goes down to the thyroid and stimulates the thyroid to create T4 and T3. When people are walking in my office, the majority of patients have only a thyroid stimulating hormone run. and they may have gotten a free T4. If we're doing really good, they got a free T4. Really, it takes a lot more than that. So with thyroid stimulating hormones specifically, right, that is a hormone that tells your thyroid to do its job. So the analogy that I use on patients is telling them, if they have kids, if they tell their kids to clean their room and their kid doesn't listen, right? So if you tell your kid to clean your room and their kid doesn't listen, you're going to tell them again. You're going to tell them a little bit louder. You're going to say it a third time, right? And that's exactly what your brain does if your thyroid doesn't listen. So this confuses patients a lot, but TSH will actually rise if your thyroid is not functioning very well. And it will rise because the brain is constantly saying, hey, bud, can you do your job? That'd be awesome, right? Then we have to go down to the actual level of hormone. So when we look at TSH, a lot of the time, patients will come in and they'll have a TSH that I would consider high, but it's not out of the reference range. So the reference range for TSH goes from 0.45 to 4.5. And oftentimes metabolically, we will just make women suffer until they get above 4.5 on TSH. Well, it's interesting because if you look at different research, right? So if you look at particularly research coming out of the fertility realm, we know that a TSH above 2.5 greatly decreases a woman's fertility, can impact a woman's ability to get pregnant and successfully hold a pregnancy, and has other kind of negative side effects associated with that. So it's funny that we medicate pretty much above 2.5 in the fertility realm, and most fertility docs would like TSH to be under 2. I would like it to be 1 to 1.5. But in the metabolic realm, we just kind of say, nope, suffer, too bad for you, you have to wait, right? So oftentimes I do see patients who are coming in where their TSH is like 3, 3.5, 4, but it's not quite out of that reference range yet. And thyroid is really a main concern for them. So first of all, brain makes TSH, right? And then if we go back, we go to the level of the thyroid, and the thyroid creates mostly T4 and a little bit of T3. So first of all, every hormone that we talk about tonight, there's a free version. And so when we're checking thyroid hormone, we want to check free T4 and free T3, because those are the ones that are unbound. So they're not bound up by a binding protein, basically put into storage. They're actually free and available to go and do the work that we're expecting them to do. So if you're getting a thyroid run, free T4 and free T3 is what we want to look at. And then we want to think about the fact that the thyroid makes about 90% T4, which really acts as mostly a reservoir. So basically what we do with T4 is we take it out into the peripheral tissues and we convert it into T3, right? T3s are metabolically active, really biologically available hormone. Then the thyroid makes about 10% of T3. So because we have to take a large amount of that T4 out into the peripheral tissues and convert it, we then have to look at something called reverse T3. So reverse T3 is something you can make when you go to convert your T4 if you are suffering from a number of different things. We'll go over those in a second. So basically what will happen is if your body doesn't feel like it can make T3 for some reason, if it doesn't feel like its metabolism should be high, it will convert into reverse T3. The analogy I use for reverse T3 is if you have a key and I have a key to get into a house, and we know your key opens the door and actually lets us in, and my key just fits in the lock but doesn't turn. That's exactly what happens at the cellular level. If I get to the door first with my key, I put my key in, right? And I go to turn it, it doesn't turn, but I don't take my key back out. It doesn't matter that you have a key because we're not getting in, right? And that's exactly what happens at a cellular level. Basically, reverse T3 is the exact same structure as free T3, which means that it fits in those receptors perfectly and it blocks up the space. Okay. And then what ends up happening is if we have a high level of reverse T3 to free T3, so this is a ratio issue, right? Then we're experiencing hypothyroidism at a cellular level. What's most interesting is that this usually doesn't show up in a CNS level. So if all you're running is a TSH, you're not going to get it. You're not going to pick this up. So things that can impact your conversion to reverse T3 or increase your conversion to reverse T3. So inflammatory conditions impact your conversion to reverse T3. Lack of calories can impact our thyroid in general, but also our conversion to reverse T3. So if we're actually not eating enough, This is contrary to popular opinion, but most women, a lot of my females in my practice come in and they always say to me, Dr. Alex, I do not eat unhealthy and I do not eat a lot and I'm gaining weight. And oftentimes you actually have to back up and ask yourself, are you eating enough for your body to be safe and actually feel like it wants to have a metabolism, right? Thyroid is the powerhouse of metabolism. So it is really, when we think about metabolism, thyroid is the king, right? And then we want to look at antibodies. So oftentimes in my practice, patients will have underlying thyroid conditions, or maybe their thyroid is slowly getting worse and they have subclinical hypothyroidism, but they have raging Hashimoto's, meaning that their TPO antibodies and their antithyroid globulin antibodies are very high and nobody's ever checked those. Okay, so we want to run those as well. Other things we want to consider for thyroid would be, we do want to consider selenium deficiency, because selenium is necessary to be able to convert to free T3. If we don't have enough selenium, we will not convert to free T3. We're going to convert to reverse T3 every time. If you don't have enough iodine, you also won't be able to make thyroid effectively. Thyroid is literally, T4 is quadriiodo, and then T3 is triiodo, which means you need a lot of iodine to be able to make proper thyroid hormone. Iodine is definitely one of those things we want to check, and we're going to be talking about how do we check our kind of micronutrients, because that's going to come up a lot in this conversation. We're going to talk about how to test those, but with iodine, you do want to test it. You don't want iodine to be too high, but you definitely don't want it to be too low, because that is going to affect thyroid function. Other metabolic disorders like celiac disease, diabetes can all affect it, and then pituitary issues can affect it. Oftentimes with patients, if you're having low TSH, right? So your TSH is low, but your thyroid is also low. Sometimes that can actually be a signaling issue, not necessarily an issue as much with the thyroid. And then I would think, if you're listening to this, so symptoms of hypothyroidism, right? Usually this looks like an inability to lose weight. It looks like a little bit of cold intolerance. It looks like constipation, dry skin, and hair loss. And then it can look like anxiety and depression. I have a lot of patients who have anxiety and depression when their thyroid goes off. The other thing that we see with thyroid issues is changes in cycle. So women who are having changes in their periods that maybe they haven't had before, thyroid is kind of really high on our algorithm of stops that we need to look at to assess that. So what if you're sitting here listening to this webinar and you're like, I have all of those things, check, 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 and my labs are normal. Well, if I had honestly $1 for every single patient that came in that had normal labs that we ended up finding out what was wrong, that would be amazing. It is really common that most of the time with thyroid, the labs just fully haven't been run, right? So we haven't run a reverse T3. We haven't looked at the ratio between reverse T3 and free T3. Oftentimes TSH is really rising and it just hasn't been talked about. And so if you're feeling like those symptoms, I would encourage you to get a second opinion, to get better labs run, and to be a little bit more maybe in depth than you've had in the past. So the next hormone we're going to talk about is insulin. So insulin is a big one for metabolic concerns, right? So most of the time when people think about insulin, they think about diabetes, and insulin is really important for diabetes. So what insulin does is insulin acts like a key, and it basically opens up the channel so that glucose can go into the cell, so that your blood sugar can go from your blood into your cell. So why do we care about this if you don't have diabetes, right? A lot of patients actually have completely normal blood sugar. So their body is still able to regulate their blood sugar normally. Their hemoglobin A1C is also normal. So their snapshot over 3 months of blood sugar looks great. But their insulin is really, really high fasting. We care about this because insulin really makes it very hard for us to lose weight, especially abdominal weight. If you are struggling to lose abdominal weight, insulin resistance can be a key component in that. Now, what do I mean by insulin resistance, right? So basically what happens is sometimes your body still regulates its blood sugar really well. It's still able to do the job that it needs to do, but it creates a lot more insulin to do that. Okay, so the cell is basically constantly flooded with insulin, and your cells eventually become immune to that signal. So it doesn't function quite as well. It's kind of like, you know what? I don't care anymore about that. And I'm not going to do what you say. So then the body creates more insulin to be able to properly get the glucose into the cell. And over time, our insulin rises. This is another one of those lab values that the lab value to me is crazy. So for fasting insulin, right, if you were just to look at the lab value and say, is my insulin normal? It goes up to something like 30. I would like fasting insulin to be about 5 to 7. And so oftentimes in patients, insulin resistance plays a big role. So what can we do about this? First of all, nutrition plays a huge component in insulin resistance. So when I'm thinking about nutrition, I'm thinking about balancing out your meals. So balancing out carbs, fat, and protein, and making sure that you're getting in enough protein to satiate yourself and stabilize blood sugar, because both healthy fats and protein are really important for stabilizing blood sugar. Other things that we want to think about with insulin would be things like chromium. So chromium is a really, really important nutrient for being able to utilize insulin at a cellular level and being able to balance that blood sugar out. The medication that we think about for this would be metformin. So a lot of people have used metformin or have heard about metformin because metformin is one of the more good researched anti-aging medications. Why do I think it's an anti-aging medication? Well, a lot of the research actually shows that it reverses cellular aging, and that it really helps patients to do well long term as they age. So with insulin specifically, metformin functions to lower insulin. And it is actually interesting because we're talking about weight, right? The other side effect of metformin is that a lot of research studies show that it helps patients to more easily lose abdominal weight. And it's a really safe medication if you have insulin resistance. So metformin can be a good choice for this and is usually what we would go to kind of conventionally, right? Oftentimes in the metabolic world, we're really waiting until you have full-on metabolic disease or you're having high blood sugar to give metformin. But again, if we look to the fertility world, we give metformin to a lot of patients who are struggling with fertility or to PCOS patients to specifically treat insulin resistance when they do very well on it. The next hormone that we want to think about is cortisol. So cortisol is our stress hormone. And basically, cortisol, when we're in a high amount of stress, makes us more resilient. It makes us better able to deal with our acute stressors. It makes our senses more heightened. And it just makes us more resilient. What happens if we're stressed out long term, right? So in our world, we're basically stressed out most of the time. And if we think about the last couple of years, a lot of people are under really chronic stress. Well, eventually your cortisol will lower. Eventually your adrenal glands will say, you know what, it's not healthy for us to have this high level of cortisol all the time. Let's lower it. And your cortisol will actually be suboptimal. Both low cortisol and high cortisol are things that we do not want. We really want cortisol to be like nice and perfect. The best way to run cortisol is actually with a salivary cortisol test or through a Dutch test, which is dry urine, which I love for hormones, and they do a really great cortisol. What this gives us is a curve. Basically, cortisol is supposed to be high in the morning, and then it slowly goes down throughout the day, and then it's supposed to be low at night so you can sleep. This is really this is why getting your cortisol curve is really important, because sometimes you can have changes in cortisol curve that you wouldn't see if you just did a snapshot. This is also why we take cortisol at specific times of the day. So if you're going to run cortisol blood, it needs to be between 8 and 10 a.m. Okay. And then the value for that, we would like it to be about 18. When we have high cortisol, with high cortisol, you are going to have weight issues. So you are going to be more likely to gain weight. You are more likely to have immune system problems, particularly upper respiratory infections, and you're more likely to have diabetes and prediabetes. Now, when we think about high cortisol from like a pathogenic perspective, that would be something like Cushing's disease. I'm not talking about Cushing's disease. What I'm talking about is a higher level of cortisol than you should have, higher than optimal, but not Cushing's disease, not where we have an actual disease process happening. Low cortisol, on the other hand, you would have fatigue, you have irritability and snappiness. So patients find that with their kids, with their spouse, with people in their life, they're just like a little less patient, right? They have decreased metabolism and they tend to have poor blood sugar control. On top of having poor blood sugar control, they tend to crave sweets more and crave salt more. And a lot of that is because the body's just looking to keep itself going, right? And sugar, your body knows that sugar is one of the things that is going to spike up the fastest. And if you were dying of starvation, right, sugar is what's going to save you. And so your body knows that. That's why they tend to have more sweets cravings. And then when we're thinking about cortisol, cortisol is really important for energy. So usually patients with cortisol issues are just tired, and maybe they're tired throughout the day or they're having a little bit of a dip. Sometimes they can't sleep at night, and that's where the cortisol curve really comes in. But cortisol is also a key component in thyroid utilization. So you have to be able to have normal levels of cortisol to utilize thyroid at a cellular level, particularly T3, which we talked about being the most metabolically active. What this means is that in patients who have subclinical hypothyroidism, or in patients where it's not showing up as much in their TSH, but they have all the symptoms of hypothyroidism, or patients who have been medicated with thyroid medication and they're not getting better, oftentimes we need to back up and we need to treat cortisol. Because if we don't do that, we really won't get anywhere symptom management wise. Okay, so we just talked about cortisol and we talked about thyroid. We're going to go into sex hormones next. But I wanted to pause and have a conversation about where hormone production starts. A lot of patients don't realize this, so they don't think about it. They think about hormone production as being in the ovary, right? True. Adrenal gland, true. But what about at the cellular microscopic level? So what I'm talking about is your mitochondria. And mitochondria are your powerhouse of the cell. So they create energy. And with hormone production, it's where all hormone production starts. And this is actually really, really important because, well, actually for a lot of reasons. So when we're looking at this graph, right, the first thing that happens to create hormone production is that cholesterol is taken through star protein into the mitochondria. This really matters. And it matters for a few reasons. First of all, it matters because if we don't get enough fats in our diet, or if we've decided to go crazy on statin medications and lower our cholesterol like crazy, we will not make adequate amounts of hormones, because we just don't have the building blocks. I always tell my patients, your body can't make something from nothing. And so if we are treating those things too aggressively, or we're really not getting enough fats in our diet, hormone production will be one of the first things to change. The other thing with this is that if we think about, so what happens is cortisol or cholesterol, pardon me, goes into the mitochondria and then is converted into pregnenolone. For hormone production, pregnenolone goes out back into the endoplasmic reticulum and then is converted into progesterone, testosterone, estrogen, etc. For cortisol, it comes back into the mitochondria and then is converted into cortisol. If we think about that, if we really step back and think about that for a second, right? If we're having, for example, menopause, where we know that our estrogen production has tanked, our progesterone production has tanked, and testosterone has most likely gone down a little bit, that means that we're going to naturally have a backup of cholesterol. We're not using quite as much of those building blocks. And so that is another reason why I think that it's important to have conversations with women about this, because there is a little bit of a rise in lipids, right, and cholesterol that can happen around menopause. And oftentimes what we do is we treat women like small men, and we're not small men, as it turns out. And so having those conversations is really important. Cholesterol is actually really, really important part of that hormone cascade. So we take cholesterol in, we convert it into pregnenolone, and then we convert it into our hormones. So having healthy mitochondria is key. If we do not have healthy mitochondria, our hormone production is going to be really, really hard to come by, right? And so what does this mean? Well, your mitochondria are really, really easily damaged. They're little divas. They're super, super sensitive, and everything that affects things will easily affect your mitochondria. We actually get our mitochondria from our moms. And when we think about things that affect mitochondria, toxins are number one. So especially fat soluble toxins. We talked about how the mitochondria easily let cholesterol into the cell, meaning that the mitochondria are really lipophilic. They like lipids. They let fats easily into them. By doing that, right, when we have fat soluble toxins and we have a fat that's gobbled up this toxin, it just brings it right into the mitochondria and then damages it. This is particularly true of basically all toxins, but polyaromatic hydrocarbons, which are things like gasoline, often found in the environment, especially when we live in things like a valley, right? Or fragrance. And fragrance is found in so many things. So fragrance is actually a fancy word for phthalates. And phthalates really, really affect mitochondrial function. Other things that affect mitochondrial function would be things like mycotoxins, so like mold. Viral infections can affect mitochondrial function, and there's actually really interesting research studies on changes in mitochondrial health, specifically following viral infections or long periods of stress. And then nutrient deficiencies. There are a ton of nutrient deficiencies that will affect mitochondrial health, or nutrients that you need to be in good ranges in order to have healthy mitochondria. So first of all, CoQ10 is a really important nutrient for mitochondria. Glutathione is a really important nutrient for mitochondria. And what's interesting is that when we have things like viral infections, right, or illness, your glutathione is really used up trying to fight that illness. And so oftentimes after illness, we would need to replenish glutathione. Glutathione also needs vitamin C, it needs NAD, it needs FAD, and it needs selenium. So a lot of these trace minerals all work together with other nutrients to kind of give a big picture, right? Melatonin is important. So with melatonin, your mitochondria actually will make a little bit of melatonin on their own, and they're really high in melatonin. Melatonin is an antioxidant. It is a potent free radical scavenger, as is glutathione and CoQ10. And so we really want to get in those antioxidants, get in those free radical scavengers, to get rid of things out of the mitochondria that we don't need. Adenosyl B12, alpha lipoic acid, and acetyl L-carnitine are also really, really important. So I alluded to talking a little bit about testing, right? So you might be thinking, okay, well, how do I know if I need these? I'm going to run out to the store and I'm going to get CoQ10 and I'm going to hope that it helps my mitochondrial function. Well, at Ethos, we don't like to guess. It's not really high on our list. And so we really do like to test. There is a test called metabolomics by Genova, which we do use a lot. It's a urine test, a urine and blood spot test, and it allows us to check all of these little trace minerals and nutrients. It also allows us to check things like fatty acid status, and that can give us a ton of information, especially in cases where maybe your hormone production isn't the answer, right? Or maybe you're just not feeling better just on hormone replacement and you feel like you need a little bit of extra. Nutrient deficiencies can play a huge role, and checking nutrients can really make it so we can tailor your treatment and get you going in the right direction. On top of that, right, in the last little bit, a lot of people have been exposed to viruses and they've had more infection. And so we do use up a lot of our nutrients in fighting those infections. And so it is a good time to check and see what your nutrient status is. I promised you that I would give you things that you can do at home. So what can you do today to help? The number one thing that you can do for your mitochondrial and in turn hormone health is to reduce your toxic burden. So there's a couple things that I think are just easy additions, right? I don't know about you, but for me, switching out some products are so hard. Like, for example, I have curly hair, right? Curly hair and really organic hair care products, I just haven't been able to figure that out yet, right? So I go as clean as humanly possible without obviously making my hair fall out or making my hair look terrible. And sometimes it's challenging, right? If you guys have a solution for that, let me know. But up until that, what I like to do is I like to focus on things that I feel like I can do. And one of the things for me that I feel like I can do to clean up kind of my toxic burden was skincare. So a lot of you know that is part of my specialty. And I feel like a lot of medical grade skincare should be clean. It should be paraben free. It should be phthalate free, and it should do what you're expecting it to do. So you actually want to use it, right? So you don't go back to the most toxic thing in your medicine cabinet. So skincare is a really easy way to get rid of some of those toxins. Also, things like body wash. So like Native, for example, which started with natural deodorant, now has like really great body wash options. And so we're just lowering down that number, right? On average, women, I think the average is something like 30 personal care products. Women put on 30 personal care products from the time they start getting ready in the morning to the time they leave their house, which is huge. And so we can change up some of those things by just changing up some of the things that we put on our body. Tarte, I didn't put this on here, but Tarte has a good, pretty clean foundation. There are tons of options. There's a ton of like tinted sunscreens where if we get your skin looking good enough, then you can just use a tinted sunscreen that wouldn't have any of the toxins in it and would just clean things up. The next thing that you can do is get rid of your dryer sheets. So dryer sheets are one of the most toxic things that you can, literally. And there are a lot of really great options. So my mother-in-law started using these dryer balls. And she said that she loves them. I haven't tried them yet, but she said that she loves them. There are cleaner dryer sheets as well. So just throwing out your bounce dryer sheets is a really, really great option. Airing out your dry cleaning before you bring it into the home. So dry cleaning is definitely one of the more toxic things that you can bring into your home. So airing it out in the garage, for example, for a few days before you bring it into your home will reduce that burden a lot. That's the same thing with if you're buying like a new rug or something, right? Sometimes you put it in your house and then you realize it's off gassing and you're like, oh shoot, I shouldn't have done that. Airing those things out in the garage is really important. Filtering out your water. So for me, Berkey is my hands down favorite water filter. It leaves the minerals in, and it leaves the minerals in, so it's going to leave you hydrated. The comparison would be like reverse osmosis, which takes out the minerals in your water, but it filters out basically everything. You can get additional arsenic filters, you can get additional fluoride filters, and it filters for like 10,000 gallons. It's definitely my favorite water filter. And then red light therapy. So red light therapy, I actually didn't mention this on the last slide, but nitric oxide has been shown to increase mitochondrial number. So like the amount of mitochondria that you have. And interestingly enough, red light therapy is one of the things that has been shown to increase nitric oxide and in turn increase mitochondrial numbers. So red light therapy can be a really easy addition. And then cold exposure. So when I'm saying cold exposure, I'm actually meaning cold to the point of brown fat activation. So when you're seeing people do things like cold plunges, that's why they do it. What it does is it activates brown fat and it will actually activate your mitochondria. With cold exposure, you need to get cold exposure to the point where you shiver. So that's important. And then the other thing that we can do is blue light blocking glasses, which I forgot to put on here, but blue light blocking glasses and some of the like sleep wake help that we do, especially when it comes to things like back here, we talked about melatonin, right? So melatonin production is important for mitochondria, and your sleep wake cycle is going to play a big role in that. So sleep hygiene, blue light blocking glasses can be really, really helpful and an easy addition. Let's get into our female hormones. Okay, so again, right, we can't just say one is the culprit usually. We have to go through the case, we have to go through symptoms, and we have to figure out what it is. So when we're thinking about estrogen, right, estrogen, we have to look at estrogen in two ways. We look at estrogen in younger women, younger cycling women, and then we have to look at estrogen in menopausal women. So when we think about estrogen, like let's say we wanted to do estrogen replacement therapy in a menopausal woman, what would be the indication for estrogen? So the indication for estrogen is normally hot flashes, night sweats, vaginal dryness, and actually brain health. Estrogen is really, really, really important for our brain health. What we know is that as we get older and estrogen declines, they've done studies where they actually did fat caliber testing on really thin women. And even in really thin women, they found that during menopause, as estrogen declined, there was a natural shift in estrogen from the gluteal-femoral region, usually associated with fertility, right? So butt and thighs, up to the abdomen. So that is one of the fun things that we get with menopause, just a natural shift of fat up to the abdomen. Estrogen is also what's mainly responsible when women go through puberty. and they gain about that like I think they say it's about like 6 pounds, right? And that is estrogen's primarily responsible for that. When we think about estrogen in younger women, we're usually thinking about estrogen dominance. Although I will say that I have a lot of younger women who are on long-term birth control pills where their estrogen is actually really, really low, and they can have closer to menopausal symptoms. But that when we're thinking about like an unmedicated younger woman, we're usually would be thinking about estrogen dominance. Estrogen dominance is really a tricky topic. And the reason why is because estrogen dominance is almost never that your estrogen is high. It's usually that estrogen is not balanced with progesterone, or it has to do with the way that we metabolize estrogen. So estrogen dominance usually shows up like heavy periods, irregular periods, fibroids, PMS. The other thing that's important to think about is that estrogen dominance is a cycle that just perpetuates on itself. So what I mean by this is that estrogen dominance will change the way that your liver clears estrogen to make estrogen be more potent in the body. Estrogen dominance can also, if you have constipation, for example, right? Oftentimes that can make it so you reabsorb your estrogens instead of putting them out in the GI tract. And all of these things will continue to perpetuate that cycle of estrogen dominance. So we really need to look at levels of estrogen versus progesterone, and then we need to look at the way you're clearing estrogen. My favorite way to look at the way you're clearing estrogen in a younger woman would be a Dutch test. I also which is dried urine. I also do use dried urine testing in menopausal women, especially if we're worried about having any history of endometriosis, things like that, or where I think that their estrogen metabolism is going down a stronger, like less favorable pathway long term. Testosterone. So a lot of the time, women kind of forget that we need healthy levels of testosterone. So we care about testosterone in women, right? We think about it more in men, but we care about it in women because testosterone greatly impacts our ability to lose weight. It impacts our changes in mood. So patients with low testosterone tend to find that they are, depression can show up a little bit, or just kind of like a low zest for life, I would say, right? So they're just a little like blah. They usually have low energy. They usually have decreased muscle mass or strength. This can be a really hard conversation with women because sometimes they don't know that they're having this, but over time they're just getting less strong, right? Maintaining muscle mass as you age is one of the most important things for aging gracefully and aging well. And testosterone really plays a huge role in this. Other things that testosterone are important for is orgasm and libido, bone density, which I didn't put on here, so is estrogen, and then insomnia. So a lot of patients don't realize you actually make the majority of your testosterone as you sleep. And what we find is that women with low levels of testosterone tend to sleep worse, and their sleep actually can be improved with testosterone replacement therapy. So why are we having low levels of testosterone? Well, first of all, right, the reference range again for testosterone is one of those things where we really want to correlate it with symptoms, right? So we want to look and say, do your symptoms match having low testosterone? And then where are your levels at? And when we want to run testosterone, you want to run both total testosterone and free testosterone. And that's because the same thing is back with thyroid. Some of your testosterone is going to be bound up by sex hormone binding globulin, which basically binds up testosterone, puts it into storage. And so when it's in storage, we don't use it very well, right? So we want the free and bioavailable testosterone to actually give us symptom management. A lot of the time, by the time we run testosterone in women, right, the reference range that we have can be kind of low. And we don't know if we ran your testosterone at 20 when things were ideal, if you would have actually been out of that reference range and been perfectly fine. So with testosterone replacement, we definitely want to be in very, very safe ranges. And we want to make sure that we're focusing on symptoms. When we're thinking about risks for testosterone being low, right? So it is different than estrogen and progesterone in that testosterone can drop early. versus estrogen and progesterone can also drop early, but are less likely, right? And testosterone can also remain high in menopause, even though estrogen and progesterone have declined. Usually it will decline a little bit, but might not drop as dramatically. So testosterone is really one of those things we shouldn't assume. We shouldn't assume based on age. We shouldn't assume based on status. We just shouldn't assume. We should test it. The other thing, we want to look at a few things when we think about testosterone. So low calorie intake will also impact your sex hormones, right? And it will also impact your body's ability to create testosterone. If we are not creating a safe, what I tell my patients, if we're not creating a safe place for our body to have a metabolism, your body is going to dial that down, right? So if it's like, look, she's been starving me for the last 6 years, and maybe for the last 6 years, you've been doing great on 1,200 calories, and then this year things changed, right? Oftentimes that's because your body's like, no, she's been starving me for way too long, and now I'm going to hold on to things, right? It's unsafe to have a metabolism that is healthy. And so low calorie intake or inconsistent calorie intake is probably more accurate, can play a big role in that, right? So what I mean by this is patients who like during the week maybe are eating like 1,200 calories or 1,100 calories consistently, but then it's very unlikely that on the weekend you're still eating that, or partway through the week that you're not having higher calorie days, because your body needs that, right? So it's going to be forcing you to eat more on certain days to maintain. Excessive physical exercise. So excessive physical exercise plays a huge role in a lot of different hormones. It does play a role in testosterone, and it does play a role in cortisol. So I do see excessive, especially excessive cardio, play a big role in lowering hormones. And if you have low cortisol that does not come up with treatment or is kind of resistant, excessive cardio really does play a huge role in that. When I think about testosterone, right, one of the most important things for testosterone is going to be lean muscle mass. And so strength training is going to be one of the most important things that we can do to maintain and build testosterone as we age. Lack of sleep. So lack of sleep is really, really, really key for low testosterone. Again, you create the majority of your testosterone in deep sleep. So if you're not sleeping, you won't create enough testosterone. And when we're thinking about, oftentimes what we want to look at is these obstacles to cure. So things that are standing in our way of getting patients better. And sleep really is one of those things that stands directly in our way. So sleep hygiene, the blue light blocking glasses, maybe dealing with some anxiety, if it's anxiety at night, are really, really, really important if we're going to move forward and actually get you feeling better. And then the other thing is oral contraceptive use. So with birth control pills lower testosterone, they lower free testosterone, and they increase sex hormone binding globulin. And so what's actually most interesting is that with oral birth control, they can increase sex hormone binding globulin as much as 7 times women who are not on oral birth control pills when women are on it. But even when they come off of it, it can increase sex hormone binding globulin up to 3 to 4 times, which means that in those patients, right, in order to get their free testosterone higher, right, their total testosterone would actually have to be higher, because a lot of it's being gobbled up by sex hormone binding globulin and held on to. So oral birth control use, even if you're not on it now, is something that we want to talk about, because it really can impact the way that we treat, the way that we feel, and the changes that we would make. So for testosterone, right, there's a lot of different ways to treat testosterone. You can go more lifestyle based and mix it with herbs, checking things like DHEA, which does convert into testosterone, and supporting the body's ability to create testosterone. Then there are creams, and then there are all the way up to pellets for testosterone replacement. And that really depends on family history. It depends on goals. It depends on life status. So where are you with things like wanting to have kids? There are a lot of different questions that we would ask, but there's a lot of different treatment strategies. And the nice thing is that means that we can tailor that based on what you're looking for, or based on what your labs need, what your body needs, and what your symptoms say. Obviously, we would be completely amiss if we didn't talk about progesterone when we're talking about female hormones. So progesterone, we think about it a lot less than we think about testosterone and estrogen for metabolism. So usually when we think about metabolism, right? People think about thyroid first, they think about testosterone second. If they're really having a lot of like abdominal weight gain, they might start to think about estrogen, right? Cortisol is probably not in there. What's interesting is that all of them play together. So I mentioned this earlier, right? So estrogen, as estrogen increases, abdominal weight also tends to increase. As abdominal weight increases, cortisol increases. And insulin increases. And as insulin increases, your abdominal weight increases more, and you end up on this cycle, on this hamster wheel, right, of all of these hormones playing together. And so that is why we can't put blinders on. That's why we can't say, oh, I'm only treating this one, in order to get the best results for patients. Progesterone, we think about a little bit less. It's not high on our list, but progesterone is really, really important for balancing out estrogen. So in estrogen dominant patients, oftentimes that can be that you don't make enough progesterone. So what's important about progesterone, right? Let's go to a cycling woman. You only create progesterone after you've ovulated, and what's left behind. So in this diagram, right by that fallopian tube, the little thing that looks kind of like an octopus, the eggs coming out, and then what's left behind is that pink little sac. That pink little sac is called the corpus luteum, and the corpus luteum is what creates progesterone. So if you're not ovulating regularly as a cycling woman, then you're not going to create normal levels of progesterone. Obviously, in menopausal women, progesterone is going to be completely different because it lowers in menopause. You no longer create adequate amounts of estrogen or progesterone, right? That's the definition of menopause. So when we're thinking about progesterone, we care about this because it's going to balance out estrogen. So this means that if you're younger, and you're having symptoms of heavy periods, you're having a little bit more of that abdominal weight, because progesterone can be important for helping patients to maintain less abdominal weight. Patients with adequate levels of progesterone tend to be a little bit thinner. And you're having symptoms of estrogen dominance, progesterone or questioning whether or not you're ovulating can be really, really important. In menopausal women, right, the technical definition of why we give progesterone in menopausal women is literally to protect the uterus from cancer. And progesterone does a lot more than that. So if you're on estrogen replacement therapy, progesterone, balancing out progesterone can be really important in terms of maintaining weight, maintaining metabolism, maintaining mood, because progesterone is a really like nice, calming, happy hormone. The thing with progesterone is that progesterone is also very water retaining. So progesterone causes a lot of water weight gain. If we think about the way that you bloat before your period when you're cycling, that's often progesterone kind of holding on to some of that water weight gain. So if you're really experiencing a lot of heaviness on progesterone, that can be that you're just dosed a little bit too high, or that things are just not quite balanced enough. So what I should have done was put an ending slide, and apparently I didn't do that. So sorry about that. But that is the end of what we would think about when we're thinking about kind of the main hormones with female metabolism.
Awesome. Well, thank you, Dr. Alex, for hosting this webinar. And thank you to everyone for sticking around to the end. Hope you learned something new about hormones and factors that play a role in your metabolism, how optimizing your hormones can make a huge difference in your long-term well-being. So if you take anything away from this webinar, I hope you understand that there is a physician out there who will take the time to understand your health, your hormones, your goals, and work with you to create that solid treatment plan that's best for you and your lifestyle. I did put in the chat, if you guys had any questions at any point, now's the time that we'll be going over them. So definitely type those in. We'll be sure to answer them. This webinar is recorded as well, so I will be sending this out via email next couple days. So stay tuned for that. You can share it with anyone that you think might be interested in this kind of information. We're always happy to share our resources. So definitely let us know if there's anything else you are interested in learning. We'll be sure to talk about that as well. Again, if you have any specific questions pertaining to your personal care, I highly recommend scheduling a free 15-minute consultation with Dr. Alexandra Mayer. She'll be able to answer your questions and help you to navigate treatment options. You can give our office a call to set up an appointment. I went ahead and left that information in the chat. If you can't find it, message me. I'll message that back to you, or I can reach out to you tomorrow as well. One last thing I want to point out is Dr. Alex has a YouTube channel, and she releases new videos every Sunday. So if you search for her name, I also left that information in the chat, the link to her channel. But if you search for her name, Dr. Alexandra Mayer, you can find her channel. It's full of resources on women's hormones, boosting your physical and mental health, all things skincare as well. So I definitely recommend checking out that channel and subscribing so you don't miss her new videos. Again, that's all we had for this webinar today. Thank you again to everyone for joining us. I hope you have a great rest of your week, and we look forward to connecting with you soon.
Thank you so much, everyone.